Welcome, everyone. So you want to give the announcement, Alex, about the channel one more time before I begin?
Give it one more time. Thank you everybody for joining. This is our first speaker meeting. I'm so happy to be here helping with tech. Before Tariq gets us started, I'm just letting everyone know again, we have interpretation as we have this available in Spanish. If you want to hear in English, please select on the bottom of your screen on the control panel, the little icon that looks like a world and select English. Una vez más voy a repetir que si quieren escuchar esta presentación en español, abajo en el menú de control habrá un icono que se ve como un mundo, seleccionar y van a ver opción de inglés y en español. Seleccionen español si quieren escuchar en español.
All right, shall I begin?
Could you repeat that again, how to get English?
Yes, of course. On the bottom of your Zoom screen,
Yes.
there will be a lot of icons, and one of them says like mute video along that panel.
Right.
There'll be a little icon that looks like a little world. It's a round one with like lines through it.
Oh, okay. Yeah.
You click that, it'll say English and Spanish, and you select English.
Okay. Thank you very much. Appreciate that.
Okay, welcome, everyone. Very exciting night. We have a large group of people. This is a very interesting topic to many of us. Before I begin and introduce the speaker, I want to thank all of those who donated to our campaign. I'm gonna say we made the goal. There's just a few 5,000 left. So thank you so much for your generosity. And as you know, NAMI is about generosity. And for those who don't know, we're the National Alliance of Mental Illness, and we run support groups, a helpline, classes, for those, and we help youth, and we work with police. We have other activities, and we do that with volunteers. So that's another place where you all can be generous. And there's something really beautiful about NAMI because it's people helping people. So we're peers. NAMI is a peer-led organization, and what that means is the volunteers and most of the staff they either have a mental illness or mental health condition, or they have a loved one. So they are all giving back, and so peer-led meaning they run our support groups, our helplines, and our classes. So if you would like to open your heart and be generous and volunteer with us, right now we're recruiting volunteers. In the chat, there's an email, info@namiscc.org, that you can email your interest that you'd like to volunteer. All right. I see many of the volunteers in the audience right now, so thank you for your service to NAMI and to the community. So I'll introduce our speaker, Dr. Po Wang. So Dr. Wang is board certified by the American College of Psychiatry and Neurology, specializing in the diagnosis and treatment of mood and anxiety disorders, and particular expertise in bipolar disorders. He is a clinical professor and past director of the Stanford University Bipolar Disorder Clinic. He has numerous peer-reviewed and invited journal articles, book chapters, lectures spanning clinical research in bipolar and depressive disorders, with special expertise in neuroimaging, creativity, and psychopharmacology. So I'm going to ask everybody to turn off your audio right now when he gives his presentation. And so we have this, our presentation is in two parts. So the first part will be a presentation by Dr. Wang, and then all questions will be answered at the end. We're going to give you plenty of time for questions. So at that time, you'll get directions, but right now I'll tell you, you can put them in the chat, or you can raise your hand, your regular hand, or you can use the raised hand icon that's on the bottom. But raising your hand too is one way, or writing it in the chat. And then we'll read it out to Dr. Wang. Okay, without further ado, thank you, Dr. Wang.
Good, I am muted. So thank you everybody for inviting me to this session. I'm really impressed with NAMI and how organized it is and all the activities you've done. It really is helpful in sort of another part of the overall treatment of clients and patients. So I'm gonna talk about bipolar disorders, and I have a set of slides. They're pretty general slides, but they have some specific information in them. I'm gonna go over them pretty quickly so we have a lot of time for questions, and you can take notes about the slides. You can we can come back and answer questions based on the slides. And you can ask questions about anything you want to. So I've been doing bipolar disorders research and treatment for about 25 years. Since I graduated from medical school and came to Stanford. So there's a whole range of things I can talk about, okay? Anything is fine. So I'm gonna try to, give me a second while I pull up my slides. 1 second, please. I'm still here, just figuring out these technical details. Okay, so I'm assuming everybody can see the slides right now? Okay, good. So I'm going to talk about the current state of treatment of bipolar disorders, including some of the biology and things like that, but mostly about the medication treatments. And I can also talk about psychotherapy, but it's not in my slides. Okay. The main thing is that the bipolar disorders is manifested by periods of being depressed. Those are represented by the yellow bars, and periods of being elevated, represented by the red bars. The main age of onset is in the late teens, early 20s. Usually it's oftentimes an onset of depression. Sometimes it's the onset of mania. It's oftentimes onset of depression more common in women, and mania onset is more often common in men. Not always the same. So what we see is that the first symptoms often occur in the late adolescence, early adulthood. And then there might be a gap, sort of a honeymoon period of several years where there are no symptoms. And you'll see that first symptoms, first treatment, hospitalization, there's a gap of years sometimes between these events. And that's because most people don't recognize that these episodes are occurring. I mean, these are pretty obvious episodes oftentimes. The symptoms are pretty obvious, but people might have a stigma about this or try to explain it away as something else and delay treatment. So that's something we can talk about. Over time, the episodes recur after the honeymoon period. They recur, and the episodes become more frequent. So the natural course of illness of bipolar is that you have these episodes recur, and they, over time of decades, become more frequent. The other aspect of this you'll see is that the episodes start overlapping each other. So you see in the 30s and 40s of age, the episodes start overlapping. So you see some mania and some depression sort of overlapping in time. And so that might be presented as what we see as mixed symptoms. It's pretty common. I just saw a patient earlier this week where they're presenting with symptoms recently of some depression with some elevated symptoms, and it's sort of kind of unclear what the patient is experiencing. But if I looked historically, when they were in their early 20s, they had much more clear episodes of being elevated, hypomanic or manic. We can describe those terms later. So looking at the course of illness of this person, we saw that they clearly have bipolar, even though the episodes right now are more indiscrete, more mixed, and unclear if they're elevated or depressed. But the course of illness is very similar to what I'm projecting up here. Okay. Not everybody's the same. Everybody's a little bit different. Some people have one episode and don't have recurrence. Very, very few people like that. Some people have a lot more episodes and progress much quicker. Okay. The things that affect this are treatment. So if you look at this graph or this chart, this is from the 1988. And back then, not very many treatment options available. Right now, we have a lot more options of treatment, which I'm going to cover. And so the course of progression tends to be not so dramatic. So treatment is important. Using substances like alcohol or marijuana or obviously cocaine and things like that, meth, that increases the speed of these progressions. Okay, so there's some variables and some factors we need to think about down the road. So if you have questions on this, we can you can save those for later. Now, even though bipolar disorder is manifested by periods of mania, feeling elevated mood, and periods of depression, and bipolar disorders is usually mostly defined by having these periods of mania. Right? People have depression and they just call it major depression, but people with bipolar can get manic. Even though that is the defining characteristic of bipolar disorder, it's really the depression that's the most predominant feature. So what this is a study conducted by Judd, and he followed patients for 13 years. They divided between patients that were bipolar 1 and patients that were bipolar 2. And he found that in the bipolar 2 patients, they were depressed half the time. They were okay euthymic for 46% of the time, and they were actually elevated for a very small minority of the time. So 1% to 3%. Okay, that's in the pink, in the red. So a lot of depression. So if you see somebody with a lot of depression, you might just think, oh, they have depression. Right? And a lot of my patients with bipolar, clear bipolar, mostly we deal with their depression because we control the mania very carefully because it can cause a lot of disability. So it's really depression we deal with from a visit-to-visit basis. So the depression, even though it's not the defining characteristic of bipolar, is oftentimes the most prominent and the disabling feature of bipolar. Even in bipolar 1, it's still a lot of the time they're depressed. Like 1/3 of the time. If you have somebody with bipolar 1, they're probably depressed 3 days for every day that they're elevated. So more prominence of depression. In bipolar 2, it's about 40 days of depression for every day of elevation. So a lot of depression in these experiences. The reason we don't just treat the depression is because, I'm going to cover that later, is because we have to respect and worry about the manias, the elevations. The elevations, people when they get elevated can end up get very elevated, and then their elevation causes a depression afterwards. So then we have to treat the elevations in order to prevent the depressions. The other thing is that some treatments that are used for depression can exacerbate or cause the manias. Okay, some antidepressants can do that. So the summary is that bipolar disorder, you have to have periods of hypomania or mania, but it's really the depressions that are the most problematic. And I'm going to give some reasons for that as well. So this is a list of some medications that are used for bipolar disorder. There's a whole bunch of medications. We can talk about all of them. So as we go into questions and answer, you can bring up any other kind of medications that you might have heard of, or treatments or interventions, anything is fine. But I've divided into main classes. So lithium is sort of the prototypical bipolar medication. It was discovered by an Australian doctor in 1949, so a long time ago. He had this idea about lithium and the reason that it would be effective. He was wrong about the idea, but the lithium did work. And because of lithium, back when we were in the United States, we're institutionalizing patients with psychiatric illness. They were all in institutions for long-term care. When lithium came around, about half the residents of these institutions were able to improve and get better and have productive lives. And so about half the institutions' residents were able to leave. So lithium has a big role in bipolar. It has less of a role as time goes on for various reasons, but it's a little bit less used now, but it still has a lot of efficacy benefit. The next group that was very well studied, and this is where I came into the research of bipolar, was the anticonvulsants. The anticonvulsants are the anti-seizure medications, and the typical one of that is Depakote. So back then, scientists and doctors thought that bipolar was actually a mood seizure. It's not a mood seizure, but they thought that. They thought, wow, these people have depression, and then they cycle into a period of mania, right? And they had some animal models where they saw that if you had more of these episodes, then your risk of having these episodes was increased, in a process called kindling. So in the 90s, late 90s and early 2000s, we spent a lot of our research effort looking at all the anticonvulsants. And it turns out that we got lucky on Depakote and carbamazepine, but we weren't that lucky on the other ones. So it turns out some anticonvulsants are effective for bipolar, most are not. So Depakote is effective, carbamazepine is effective. Turns out lamotrigine is effective, but these other ones have limited efficacy benefit. Okay, we can talk about those. The category of medications, the new antipsychotics. This category, we didn't really think much about in the past. So these are medications that we see a lot of right now. Zyprexa, Seroquel, Abilify, Latuda, Vraylar. This class of medications is very commonly used right now in psychiatry. The reason we didn't think about it very much in the past, because the first generation of these medications were things like Haldol and Thorazine, Navaine, all those medications that had a lot of really serious motor side effects like tardive dyskinesia. So because of those serious side effects, we tended to not use those medications except for mania, right? But because there's a medication called Clozaril, it's listed on there, was used for very difficult to treat patients with bipolar, and it found some benefit there. Because of that, this whole category of medication started being developed and looking at its use for mania. Okay. This new class of medications doesn't have the same side effect burden as the old class. It has new side effect burden like metabolic issues, weight gain, sedation, things like that. But it doesn't have the tardive dyskinesia or neuroleptic malignant syndrome, those things. So it has a different set of things. The reason this class of medication is so well or broadly used now is because unlike the old medications that work well for mania, that actually cause a little bit of depression. These new medications, they all work for mania, well, most of them. And some of them actually help for depression also. Okay. So it actually sort of broadened the benefit range of some medications that we had. Prior to that, we didn't really have medications for bipolar depression, which is why there's maybe one reason where there's a lot of bipolar depression. We didn't have a lot of good treatments for it. I didn't mention antidepressants here, right? Because it's the next category. They tried to use antidepressants in the past for bipolar depression because they tried lithium and it worked a little bit, but it didn't work that much. So they tried to use antidepressants because some people would be depressed for a long time. And some people, when they use antidepressants, would get manic. They'd flip from a depression into a mania. The problem with that is that they get manic and they crash into depression afterwards. So you would not be in a good situation, right? So prior to the 1980s, we might have used antidepressants, but soon after that, we found that there was a liability of using antidepressants for bipolar. So these antidepressants we don't use as much of, but we still use them because bipolar depression is still difficult to treat sometimes. And then there's a whole bunch of things that people have looked into, looking at other mechanisms to see if we can intervene with bipolar. So people in the past, not so much now, have looked at benzodiazepines. So there's some really old studies of benzodiazepines, looking at treatment for depression and mania. Generally speaking, not very effective for bipolar. Useful for certain aspects of bipolar, but as a bipolar itself, not very effective. For people with bipolar has anxiety, helps for that sometimes. People with bipolar have insomnia, helps for that sometimes. But the bipolar itself, the mania, the depression, doesn't help that much. Then there are like the old antipsychotics that we just talked about, the Haldol, the Thorazine. We don't use them that much because it causes some depression. But for some people that have really difficult to treat mania, or maybe their manias have some psychosis, then maybe some of these medications can be used. Thyroid hormone is something to think about. Some people with bipolar and mood disorders have thyroid abnormalities. Some people don't, and still the thyroid hormone can be augmentative help. And then there's TMS, ECT, modafinil. There's some other things as well. So if you have heard of anything, we can bring it up and maybe I can have some information for it too. So though that's sort of the range of things we can think about, and I'm going to sort of get to some more specifics. There's a disparity between what psychiatrists do in the community and what psychiatrists do in the academic center. The patients may be a little bit different, the types of patients, the difficulty problems, but they're kind of the same. The difference is that in the community, maybe it's not fully understood that bipolar depression shouldn't be treated with antidepressants. So what you see in the community is a lot of antidepressant use. Again, because bipolar patients oftentimes have a lot of depression. So you expect a lot more antidepressant use. They have a lot of insomnia. So you see a lot of hypnotic use. And this anticonvulsants, lithium, antipsychotics is less. Right? Even though lithium was very the defining characteristic of bipolar and it really helped people a lot, it's not used as much now. Right? So antidepressants are the most commonly used in community. It's getting less because people are more, clinicians are getting more adept at watching for that. But it's still probably the most commonly used medication for bipolar in the community. In academic centers where we see some cases that sometimes are more difficult to treat, and we tend to have more mood stabilizers. This is a study from 2006. So back then, the mood stabilizers like Depakote, valproic acid, VPA is valproic acid, CBZ is carbamazepine, LI is lithium. So we use more of the mood stabilizers. Remember I said that when I got into bipolar research, it was in the late 90s, early 2000s. So that's why we see more of that. Now we would see more atypical antipsychotics. It's like Prexis, the Seroquels, the Abilify, things like that. But you can see that there's more. If you combine the Depakote carbamazepine column and the new antipsychotic column, that's going to be bigger than the antidepressant column. It's not that we don't care about depression. It's that we've also, we really worry about perpetuating the cycling. It's an illness. That the cycling is the illness that we're trying to treat, not just the depression, not just the mania. We're trying to treat the whole illness itself. And we're trying to avoid antidepressants because even though we're trying to treat the depression, we're trying to use other agents that can help the depression without perpetuating this cycling. Okay. We use hypnotics, but we try to use that at minimum if we can. So what are the different strategies for treating bipolar disorder? Okay. I'm going to try to separate this out and see if it makes sense for everybody. It goes from earlier types of treatment, like a while ago, what people would do, to more contemporary treatment at the bottom. So in the past, we used to think of bipolar as people with mania, people with depression. Sometimes it'd be manic, sometimes it'd be depressed, right? And if they were manic, we would give them something for mania, an anti-manic medication. And if they're depressed, we would give them something for that. In the beginning, if they were depressed, we give them an antidepressant, they get manic, and then it gives them for mania, and then they would get depressed. Then it gives them for depression, and then get manic. So it would go back and forth, right? Maybe that contributed to some of the progression of their illness in the past. So that's what they used to do in the past. They would treat the mania because that was more unstable, and they would treat the depression. Separate entities. It'd just be like a person would have these two things, and you see one thing, you treat that, and you see another thing, you treat that. But you weren't treating the bipolar as a whole. The next level of that, the more contemporary version of that, is you treat the mania, yeah, you treat the mania, right? But when they're depressed, you want to make sure their mood is pretty stable before you treat the depression. So you might do a mood stabilizer like lithium or Seroquel, something like that. And then you would only add an antidepressant on top of that. So you respect both at the same time. You try and treat the whole person, the whole course of illness. You're not separating them. Okay. So the difference is that the first row, you might use an anti-manic, they might use lithium. And then when they're depressed, you might stop the lithium and start something else, right? And the second one, you're like using lithium, get them out of the mania. And if they're depressed, you would make sure that their mood is nice and stable. They might be depressed, and then you got antidepressant, get them out of that. The reason we did that is because we didn't have a lot of medications that were effective or useful for bipolar depression. So we had to use antidepressants. Okay. Lithium is about, if you give somebody with bipolar depression lithium, it helps about 30% of them. So some, but not most. So you'd have to use an antidepressant. What's happened in the contemporary sense, and again, not all psychiatrists do that, and a lot of psychiatrists don't, is what we're trying to do is treat the bipolar illness as a whole entity. Bipolar patients get depressed, they get manic, but it's part of the same disease and disorder. They cycle, that's part of the same treating. So the main thing we're trying to do is treat the mood instability. We're trying to stabilize their mood. We're trying to treat the mania and the depression together. Okay, not as separate. We see them, even though it's affecting the person separately, we're seen as sort of part of the illness, being unstable. And so you could use both, right? Those agents, but some of the agents that we have now, some of the medications we have now, actually are good for mania and good for depression. So we're trying to get a true mood stabilizer that works for both mania and depression. We don't have a whole lot of those, but we have some, right? And that's the direction we're trying to get to. Okay. That's confusing sometimes, but so if you have questions, just hold those and we'll come back to those. Okay. So this is a complicated slide, but it's actually not that complicated. So this is a pyramid of how we decide which medication to use versus another time. So this is talking about effective treatment. So effective basically means like how well the treatment works in the real world. Like if I give the person Zyprexa, so Zyprexa is a medication that a lot of people have heard of. Zyprexa works very, very well in an ideal situation. If the person doesn't worry about being over-sedated, if the person doesn't worry about gaining 60 pounds, then it really works really well. But the problem with Zyprexa is for every person that you get better, they gain a bunch of weight. So it's a 1-for-1 almost, right? So its effectiveness is limited by its weight gain and sedation, and also metabolic issues like diabetes and cholesterol problems and things like that. So the top are things that like Clozaril and olanzapine, which is Zyprexa, and Risperdal and quetiapine, which is Seroquel. Those are things that have a lot of benefit, but have a lot of side effects. So if somebody's in the hospital, you might see somebody using that as a medication. At the very bottom, you see things that are antidepressants: fluoxetine, FLX, sertraline is Zoloft, PAR is paroxetine, S-citalopram is Lexapro, desvenlafaxine is Effexor, DLX is duloxetine or Cymbalta, bupropion is Wellbutrin, and mirtazapine is Remeron. The information is not so relevant, but antidepressants are usually pretty well tolerated. In bipolar, they have some mood cycle, but they're generally pretty well tolerated. One step up from that is lamotrigine or Lamictal. Actually quite well tolerated. The difference with lamotrigine is it doesn't work that well for mania. It works for a little bit of cyclic, but it doesn't work for the intense cyclic. It works for depression. So it's good tolerability, but it doesn't have a full range of benefit. And it doesn't have, and its benefit is not as robust as some of the other medications. Lithium, not as well tolerated as Lamictal. Depakote, not as well tolerated as Lamictal. And carbamazepine, not as well tolerated, but they work better for mania and mood cycling. And then you have these other things in the middle. Ziprasidone is Geodon. Aripiprazole is Abilify. Asenapine is Saffris. And lurasidone is Latuda, right? So the concept of this is that some medications are more tolerable, some medications are more intolerable, some medications are more efficacious, and some medications are less efficacious. So that's where the psychiatrist comes in with the patients, and figuring out what people can tolerate, what they can't tolerate. It's not like yes or no. It's like what can people tolerate, what they can't, right? And how much benefit they get, how much they don't get. Right? So if I give you, like for instance, Lamictal, and it doesn't help your mania, but you can tolerate it, it's completely worthless, right? If I give you Clozaril, you can't wake up in the day and you're sleeping all the time. That's probably not good either, right? Even though you're not manic. So balancing that out is the whole benefit of figuring out how the medication regimen or the treatment regimen is going to be the best. That's the art part. So this is a list of all the FDA-approved agents for bipolar. There's other agents as well, but these are FDA-approved ones. So I'm going to point out a few issues here. The acute mania category has a lot of medications. Basic lithium, Tegretol, Thorazine. Thorazine is the only one because it's from that grandfather period of time. They let it in. And then you can see a bunch of, since 2000, a bunch of atypical antipsychotics. It's like, I'm just going to go down the list. Olanzapine is Zyprexa, Risperdal is Risperidone, Risperdal, quetiapine, and you go down the list. Okay. The long-term treatment, it's not something you have to think about too much. Okay. These are medications that have been studied for longer-term use. So like some of them have been studied for 18 months, some for a year, some for, mostly a year. Okay. So that just shows that if somebody gets better on Zyprexa and you continue Zyprexa, they continue to be better. That's all it really says. The biggest column I want to talk about is really the column that has the smallest number of agents. Now, when I was talking before, when I got into bipolar treatment, look, 2003, right? So I've been around for a long time. Before 2003, I think 1995 is when I've been around. There was no medications. These are all from 2003. There was no medication approved for bipolar depression. So we were just trying to figure it out back then. But since then, there's been 2003, 2006, 13, 19, and 21. There's been quite a few medications for bipolar depression because we do a good job with mania, but we're lacking in the number of agents for bipolar depression. Okay. Again, as a summary, that's the category of that we need the most help in, because that's mania causes a lot of disability, but chronic disability, where people can't get out of bed, can't get a job, can't have good relationships, stuck at home, that depression can be a big issue. And that's the phase we need to talk about. Okay. So I went over that in about pretty quickly because I want to have a lot of questions and go into the depth with this. Okay, I think that's my last slide. So I can, I guess, unshare, and then that's probably the best way to do it. Let me see how it is. Oh, here it goes here. I think I stopped sharing, right?
Yes.
Okay.
Thank you.
Yeah.
If you want to see everyone, you can just like gallery view. But I do have a couple questions that I had on the chat.
Yeah.
And if you have a question, I see Joy has her hand up, so I'll put you on the list here. I'll let you know when you can unmute. And as you go along, if you just want to raise your hand, I'll try to keep that note. The first question I have for you is from Jen, and her question is, does Seroquel work for bipolar depression, or is it better for mania only?
Okay, so this is for Jen. So Seroquel, also known as quetiapine, it was actually the first medication that found benefit for both bipolar depression and bipolar mania. So it's actually first approved for mania, and then a few years later it was approved for bipolar depression. It was actually the first medication. Well, there was a Zyprexa, but it was not Zyprexa by itself. So it was the first monotherapy by itself. In fact, it was the first medication that's approved for bipolar type 2. All these medications, most of them, the majority of them are approved for bipolar 1 only. And the reason is because it was easier to study bipolar 1. So Seroquel is approved for both depression, and it's very good for mania as well. The reason people use it for depression more is because psychiatrists are a little bit wary of using it for mania because it doesn't work as fast as some of the other ones like Risperol or Zyprexa. The reason it doesn't work as fast is not because it doesn't work very fast. It does work fast if you get to a good dose right away, which is 600 milligrams. It doesn't work as fast because sometimes people get lightheaded and low blood pressure. And so you have to figure out a way to adjust the dose quickly to get to that nice dose. It's a technique that's easy to do, but that's probably why people don't use it as much.
Thank you. Is that question answered, Jen? Thanks. Our next question is from Nicole. Can you talk about circadian rhythms and bipolar? With a side note of, I've been very happy with a small dose of lithium for 10 years, but I have some insomnia, usually waking up 3 or 4 a.m. most nights.
So that's a really good question. That's a super good question. It's particularly good because, well, let me just say it this way: that bipolar illness is highly tied to the light cycle. And let me just say it that way, light cycle. So the circadian rhythm is a part of the light cycle. So some people, for instance, will have what we call diurnal variation. They'll have a shift in their mood from the morning to the night, right? Most people are depressed in the morning and elevated at night if they're going to have that cycle. So some people have that daytime shift. Some people will have a seasonal component. So they'll be elevated in the spring, depressed in the fall, winter. So they have that seasonal component. And the third component of the circadian rhythm is like patients with bipolar are particularly sensitive to travel, time zone shifts. So I definitely have patients that when they go to the East, it's not so bad, but when they go to Europe, it can be like hospitalization, right? So we have to manage that. And if you go to Asia, also many time zones, it's a big problem. So that circadian rhythm is a big issue. There is like some data looking at circadian rhythms in animal models. Like there's a mouse that has their circadian rhythm gene affected, and they kind of act kind of manic, okay, and they get better with lithium. The other issue that you brought up is looking at insomnia. That's not exactly the question you brought up, but it's brought in your history. And that is that there's a high concordance. There's a lot of people with bipolar that also have insomnia. Their mood is fine, but they have a lot of insomnia. So this is some work done by a psychologist at UC Berkeley. And she looked at sleep disorders and bipolar and found that at least a third of people with bipolar, when they're stable, their mood is stable, they still have insomnia. So that's a risk, insomnia, obviously, for a mood episode. Doesn't mean it's the same as mood episode, but they're at a risk. So we really need to be vigilant about maintaining good sleep hygiene, good sleep duration. And so we need to, waking up at 3 to 4 is probably a little too early. So you need to work with your psychiatrist or your provider about how to manage that.
Thank you. Does that answer your question, Nicole?
Yes, thank you.
Thank you. Our next question is by Alexandra. Her question is lithium the only medication that really works as a mood stabilizer?
That's a really good question too. All these questions are really good. No, the short answer is no. Okay. When the term mood stabilizer came about, bipolar academic clinicians like myself, we were always interested in stabilizing mood. Like we knew that we didn't want to treat mania and treat depression. We want to treat the whole thing. We want to stabilize mood. But at the beginning, we didn't really have anything that worked for both mania and depression. And so we just made up a term. We said mood stabilizer is something that helps the mania or helps the depression, but it doesn't cause a worsening of the other. So in other words, Haldol is not a mood stabilizer because it helps the mania, but it makes people depressed. So it worsens the depression. An antidepressant is not a mood stabilizer because people will be not depressed, but they may be manic. Right? There are some old antidepressants called tricyclic antidepressants like nortriptyline or dizipramine, and they look like they were effective for bipolar because half the people on these medications got better from their depression. But half of those patients that got better were manic, actually. So they didn't really get better from their illness, they just got better from depression. So since then, we changed the definition of mood stabilizer because we have other agents. It's not just something that helps one without worsening the other. There's a few medications like Seroquel, I mentioned one, and Vraylar's one, and there's Abilify may be a little bit of one, and Lamictal's a little bit of one. They have benefit for both sides. Lamictal's really good for depression. It's okay for the elevation. It's not good for mania. They're a little elevated, it's okay, right? So each of these, there's different ones that are good mood stabilizers, but to different degrees because they have varying benefits for the depression and varying benefits for the elevation. So that's where you need to talk to your provider to figure out for your particular situation, what is your main symptom and how much emphasis we need to put on that versus the other.
Thank you. Alexandra, does this answer your question? I'm gonna hope yes. Joy, you can unmute and you can ask your question.
Sorry. Oh, I put it in the chat. I was wondering, so this person thinks it's everyone else's fault. She will not, she doesn't realize that anything's within her control. She feels like a victim. She refuses to get help. She refuses medication. She's got a narcissistic personality disorder and extreme paranoia, but I'm not sure she has bipolar.
All right, I'm sorry. Are you asking a question?
Yes, could you just kind of speak to that?
So there's a lot there. I'm because I haven't seen the person, I'm not gonna make a comment about the narcissistic personality disorder. It's pretty common for people. Do you know how old this person is?
82.
82. Okay. I was gonna say it's pretty common for people when they have when they're early in their illness to not take responsibility for it, not recognize it because it's so foreign, right? As time goes on, um, that inability to take responsibility, right? I'm going to talk more about that in a second, is a limiting factor in their ability to improve. What do I mean by that? When somebody has bipolar or schizophrenia or depression, any psychiatric illness that we're talking about here, these biological medical illnesses, right? These are biological medical illnesses that present in the brain. You can't see anything in the brain. All you can see is like what people do, right? But these are biological illnesses because if you look in the brain, there's something going on there. If we don't recognize this in the brain, then we just try to change behaviors all the time. And these illnesses, we can't just change behaviors sometimes. Some of these illnesses we're talking about, right? And because we can't just change behaviors, we have to recognize what the behaviors are or the symptoms are, and we have to recognize them in order to get help, right? So that's that responsibility. The person is not responsible because they're doing some of these symptoms, some of these things. Maybe people are irritable. That's a common symptom, right? Well, people are irritable not because they want to be angry at people, there are people around them. Often it's irritable because it's really difficult to be them, right? So I have a lot of people that are irritable with me, but I try to not be affected by it because I know they're suffering at that time, right? And usually if I recognize they're suffering, then their irritability calms down because then they know that we're on the same page, right? So that sense of needing, not being blamed for the symptoms, but taking responsibility for the treatment is that dichotomy that needs to be managed, okay? When somebody's a little bit older, it's more difficult to change that dynamic. So somebody's 82, it's very difficult to change that dynamic, but it's still necessary because it's hard to force somebody to take meds, right? It's hard to force somebody to engage in therapy. It's really hard to force somebody to engage in therapy and actually do it, right? So that's the responsibility that needs to be done. And that's where this balance between understanding that there's something going on, but actually, and not feeling like guilty about it, but actually still taking responsibility, because if they don't take responsibility, who is, right? I know NAMI, a lot of family members are involved, but in the end, we all know, right? If the designated patient doesn't want to do it, so that's where the responsibility comes in. They have to at least help, right? They don't have to do it all, but they have to help, right?
That helps, Joy. Okay. Our next question is from Pip. Could you talk about bipolar and alcoholism?
That's like a huge, that's a big question. So I'm gonna touch some elements of it I think are really important. Okay. This is really good. I'm gonna follow along with what our last question was, because alcoholism is one of those illnesses. There's a lot of biological parts of it, right? But it's like specifically excluded by the government as something that is like your own fault, right? It's one of those things like if you have alcoholism, we're not going to cover that because that's your own thing. Personal responsibility involved with that, okay? And that sort of is the next step of bipolar. It's like, oh, you need to manage your mood better. It's your own thing, right? So bipolar and alcohol, they are highly associated. About 70% of people with bipolar have had some kind of substance abuse, with alcohol being the most common. Right? So maybe there's some personal responsibility. You don't have to drink. Maybe it's some of that. On the other hand, if you have bipolar and you're having a lot of depression, you need some relief for that. Or you can't sleep because you're elevated and you need some relief for that. Or you're manic and you don't perceive risk as much. Maybe those things lead to alcohol abuse. So there's a high concordance between alcohol and bipolar. They're not the same thing. It's not the same, but there's a high concordance of those things. As in any psychiatric illness, if you don't treat the alcohol, then you don't treat the mood. Because, believe it or not, alcohol is more immediate and stronger than lithium, right? Lithium, you take it and it doesn't sort of help right away. Whereas alcohol, people get really intoxicated really fast. And there's not a control in how much they take. It's available in the community. So that's the problem with substances, and alcohol is one of them, right? If we don't treat the alcohol abuse, we can't really treat the mood. Now, obviously, if we don't treat the mood and we don't, and we just want to treat the alcohol, that's hard too, right? But I'm just saying, if somebody's like drinking, and we try to give them something like for their mood, very hard. It doesn't really work. Of course, if somebody's trying to stop alcohol and they just try to treat the alcohol and their mood is depressed, it's very hard too, right? So it's both, but the priority is treating the substance because it's so, the effect is so strong. The third thing I'm going to say about this is that if you don't, if you have to treat both, right? Certain medications are better for people with alcohol and bipolar than others. It's like lithium. Lithium doesn't work so well if you have substance abuse. It should work, but it doesn't work as well. Even if the substance abuse is stable, people have had substance abuse, they just don't respond as well to lithium. Okay. So alcohol and other substances has a prognostic effect on the bipolar. The final thing I'm going to say about this is that sometimes people will misdiagnose alcohol. They'll misdiagnose alcohol as bipolar as alcohol. Okay, in other words, people that binge drink, right? So sometimes they'll be drinking and they'll be like doing some kind of erratic things. They might be looking like manic, right? And then when they're intoxicated too much, they might look like they're depressed, right? So some people might think of that as bipolar. On the other hand, people that have bipolar, they really have bipolar, they might think, oh, it's just alcohol. So really, it's important to sort of tease these things out. I don't know which one it is sometimes, but for various people, for different people, we really need to sort of look at both, respect both, and treat both. Okay. There's other things to talk about that, but it's a broad question, so I want to ask. We'll go on a little bit.
Yeah, thank you.
That was fantastic. Thank you so much, Doctor. I really appreciate it.
Thank you. Our next question is, can you talk about the pathophysiology of bipolar disorder?
Man, that's a really hard question too. I wish I could just say, bipolar is on gene 21 and it is like this part of the brain. I spent like half of my career doing that, looking for the cause of bipolar. Let me tell you something. When I got into psychiatry, I wasn't really that interested. I'm more interested in the biology and the imaging. When I was in medical school, I did research in brain imaging. That was my research. And my professor in medical school, he tricked me. He didn't really trick me, but he believed that he knew the cause of schizophrenia. He didn't know, but he thought he knew the cause, and because there was a really prominent cause back then called the flu at a certain time of the pregnancy, and so he said, "We know the cause of bipolar. I mean, of schizophrenia." I said, "Wow, we are like so far advanced." And so I started studying the cause of bipolar. We didn't find it, okay, but what we found was that there's a certain part of the brain called the anterior cingulate in the anterior paralimbic. So that, oh shoot, I don't have a brain with me. But that is the part of the brain that is deep, and it goes around the central part of it. It goes apart this little white matter part. So if I point at my head, it's sort of in this part right here, okay, but deep. If I look sideways, it's this part right over here. So it's like deep. It's a deep part of the brain, and that part of the brain governs your emotional processor. Okay. So if you're depressed, it involves that. If you have bipolar, it involves that. And that part is connected to the hippocampus, which is involved with cognition and memory. And it's involved with the amygdala. That's part of this anterior paralimbic. These are some words you probably heard of. The amygdala is important involved in like fear response, fear recognition. So like, for instance, one of my colleagues in the past, her research project was looking at patients with bipolar and their fear response. And they found that people with bipolar could not differentiate between fear and excitement. Think about that, what that means. They show them pictures of people that are afraid versus people that are happy to see you, excited, right? And they couldn't tell the difference. What does that mean? That means like when somebody's manic and they come to you and you're scared because you're like, yeah, you're acting kind of like bizarre. They just think you're happy to see me and they keep coming, right? So maybe that's not risk intolerance. Maybe they're not afraid of risk. They just don't recognize it, right? That's a brain thing, right? So that's not like that. He's like clueless. It's not that. It's like a brain thing, right? So that anterior paralimbic is part of this pathophysiology, right? They look at genes. They look at certain things like that. There's 3 ways of thinking about the pathophysiology of bipolar. This is the brain circuits, right? And I spent a lot of time doing that. I'll just carry this forward a little bit. So because of that, we thought, oh, wow, we found the circuit. That's important, right? And a lot of studies found that. So we started figuring out how can we intervene in that way. So one thing we tried to do was we found, well, are these parts of the brain different in people that are responding to Depakote versus not responding to Depakote? Could we use it as a response predictor? And we said, yeah, you can, but it wasn't very good, right? So I could tell the difference between 20 people that responded to Depakote versus 20 that didn't, but I couldn't tell 1 to 1. So it's not a good predictor, right? So that didn't work. And then the next thing we try to do is we try to put electricity in that area. Not many people want to do that, right? And obviously that's the case, right? So some of the studies were from Helen Mayberg she was from Toronto, went to Atlanta. And so we did some of those studies too, deep brain stimulation. That works, but you don't do it very often, right? The next thing we try to do is we try to do something called cyberknife. So radiation therapy, but focused radiation. So like, if you have a brain and you have cancer in the brain, the thing is, if you want to operate and cut through all the good stuff and the person's personality is all different or not have a personality at all, sometimes you can't do that, right? So they developed a treatment called a focused radiation beam. So they hit the brain with different radiation beams. And so it doesn't hurt, but then that one place where it focuses, it kills the cancer. That's what it does. So we applied that to bipolar. We hit that part of the brain that we thought was important, the anterior cingulate, but we used low intensity, and that really worked. We only did 3 people. Those people all got really a lot better, but then it burned a hole in that brain. And the FDA said you can't do that. Okay. And we didn't really want to do that anyway. We don't want any burning holes or anything like that. So we try to affect that part of the brain. And then we stopped because that was it. You can't intervene anymore, right? And then in the last few years, like 2 or 3 years, TMS, transcranial magnetic stimulation. It's a magnet that affects the first centimeter in the brain. It doesn't go very deep, so it doesn't hit the part I'm interested in. But it hits the certain parts of the brain that then are actually connected to the parts that I'm interested in, anterior cingulate. So if you hit a certain part of the brain, you can monitor the part that we talked about, the anterior cingulate, and see that it actually changes. So that brain circuit is still relevant. It's just that we're trying to figure out how to get there, right? And then there's genetics. The pathophysiology involves genetics. And the summary of that is there's populations of people, small groups, some Amish groups and some other groups, that they have a lot of bipolar. And you look at their family and you can find genes in their family that's related to the bipolar. But if you try to find that gene somewhere else, you don't really find it. Right? So there are some high yield genes, but they're not widely prevalent. So it has a big effect, but not many people have that effect. Okay. So that contributes to this pathophysiology model, but not to individual care, because most people don't have those genes, right? So the third group is we already talked about a little bit, which is the circadian rhythm. So now we're talking about like what other parts are important, like circadian rhythm is important, right? So that's also important, which we mentioned, like the time change and the season, that's important. But I mentioned that there's a mouse where you can take out the circadian rhythm. There's a gene called the clock gene, right? And if you take out the clock gene, they kind of don't know what to do with their time. And they're just like sleeping all the time, or they're awake, they're not really sure. You take that out, these mice actually act a little bit manic. So they're a little more hyperactive. And mice, if you put them in a lit room, then they hide. They don't like to be in a lit room. They hide in the corners. They try to like hide under stuff. You don't really, they try to avoid being seen. But these mice, they don't care. They're just hiding out in the middle of the room. They don't care. If you give these mice substance to abuse, they abuse the substance and get addicted to the substance much faster than other mice. And the final thing is if you give them lithium, then they start acting like regular mice. They get addicted less, they start to get afraid again more, and they're less hyperactive. So there's a lot of pathways towards knowing that this is a brain illness. And we know some brain circuits are involved and some genes that are involved, but we have to be a little bit more awoken now. And we don't know actually how these fit together yet, but we know these parts are important.
A great summary, thank you. Our next question is by Nicole. For bipolar 1, what are the best first-line recommendations as a sleep aid?
So the first line recommendation I would for a sleep aid, because as I said, insomnia is pretty common, is I would choose one of their mood stabilizers that is a little bit more sedating and try to lower the dose more at night. So for instance, like most of the ones we have are sedating. Some of the older ones like Depakote, a little bit sedating. Lithium, not as sedating. Carbamazepine, not as sedating. Zyprexa, very sedating. Seroquel, very sedating. Risperidone, very sedating. Acenipine, very sedating. It's only until you get to Latuda, Abilify, Vraylar, those are less sedating. Caplyta, very sedating. So the number one thing is to try to keep your the medication regimen as parsimonious as possible. So you treat mania, treat depression, and treat insomnia with the same agent. That only works part of the time because it's a difficult process, right? So then you try to say something, you use something that's less addictive. Again, it's not you're blaming anybody, but there's a risk for more addiction in people with bipolar. So if you can avoid something like that, be useful. Also, like some of these addictive things have more cognitive effects. So we try to avoid that as well. So things that would be effective for sleep might be things like gabapentin or Benadryl or hydroxyzine or trazodone. Trazodone is like a weak antidepressant, good sleep agent, those kind of things. And if you can't do those things, maybe you can do some kind of what we call Z drugs. These are kind of sleep agents, but not as addictive, like zolpidem, Ambien, or Belsomra, things like that, right? We try to do those things. They have a little bit of addictive potential, but not as much as the other ones, like Ativan or Klonopin, things like that. You know, sometimes you have to reach for those, right? The benzodiazepines, because other things don't work. And sleep is important, right? So sometimes you have to reach for those. Try to avoid them if we can, but I tend to have to use them sometimes. It's a difficult problem.
Thank you for that one. Our next one is, and I do want to note we're at 7 and we end at 7:30. So we still have some time for questions. Our next question is by Macy. Macy, can you please talk about ECT and TMS? Lithium causes trembling and other drugs don't seem to be working.
So ECT, TMS, I'm going to talk a little bit more about, but ECT. ECT is basically has been the definitive treatment for depression. Depression, any kind of depression. Major depression, unipolar depression, bipolar depression, works for that. You have Huntington's disease, you have Parkinson's disease, you have depression, it works for that. It works for all that. You have cancer, you have depression, it works for that, right? It works for all that it works for all that depression. Probably the reason it does that is because you cause electrical current, people have a full seizure, full body seizure all over the brain. And so it's kind of a rough hammer. It just hits everything, right? And so it has a lot of chemical effects. If you check like serotonin level, it goes up, it has a big effect. And so it's kind of like a bomb. It does everything, right? And so it's not very specific. And so that's why it works, right? We're hoping that TMS hits the circuits a little bit better, but we don't know for sure. TMS providers say it does, but we need more evidence for that down the road, right? So TMS also effective for depression. It's probably also effective for bipolar depression, but the study is not fully done. So there's some studies for it, but not fully robust yet. Okay, there's some studies. So TMS is good for unipolar depression, but bipolar depression is not yet approved and insurance don't cover it. And because it's not covered, the cost is expensive. Okay. So I think it does work. The issue with TMS is that, and I've talked to Nolan Williams and people that do TMS. Nolan Williams is kind of the big proponent and big researcher and practitioner of TMS. The issue is that if you do TMS with bipolar depression, quite a few people get manic. Okay, so if you do it and if you don't know how to do TMS, you get in trouble. If you get manic, you stop, and then you're just stuck. But it turns out TMS, like ECT, some people get manic too. If you see people get manic, you just keep going, and then ECT is actually good for mania. With TMS, you don't keep going, but you switch sides. There's a different part of the brain that can actually be a little bit anti-manic. Again, this is all research stuff. This is kind of something hopefully that'll be a little bit more robustly used and more commonly used in the future, but I'm just sort of giving cutting edge information. You may not see it anywhere else, but basically TMS is probably good for bipolar depression. I think it is, but you got to be careful who does it, because you got to be able to switch it to something else to treat the mania that's emerging. And once you do that, you can get them pretty stable, but you got to watch out what you're doing. So that's why we have a study right now at Stanford looking at bipolar depression with TMS, but they're looking for people with bipolar type 2, because if people get elevated, they want to get them psychotic in the hospital. So they're afraid of that before they get the benefit down. But I know they've done the other stuff in the past just to get proof of concept. But right now we're still being careful about it. The other concept that we're talking about is lithium caused trembling, and other drugs don't seem to work. Yeah, I do consults in my Stanford clinic, and that's a common thing that happens. People come to me and they have a psychiatrist, and they've been on, the quote is, they've been on everything. Okay. 25 years ago, people have been on everything, and they really had been on everything. And then we'd have to come up with stuff, right? We'd have to come up with sort of things that look like things that would work, things that have the same mechanism of things that work. So we tried some of these things. So I tried all these anticonvulsants, like all the anti-seizure medications, looking at things that had a little evidence, right? We did all that stuff. Today, there's a lot, as I showed in the chart before, that there's a lot more medications for bipolar mania, right? Or bipolar cycling. And the combination is that you can combine things, right? And if you combine things, you have side effects like tremors with lithium, you can do something about that. Like, for instance, lithium tremors, you can do something about that. There's some, you need to decrease the dose. There's certain medications you can give that can decrease the trembling. There's certain, like propranolol can help with that. There's other things that can affect the kidney that can decrease lithium tremors also. You got to be careful about how to do that and who's doing that. So there's things that we can do that are more complex but are doable for people that are what we used to call treatment resistant, right? You can do different combinations of things. Some combinations work better than others. You can do like things that help with the side effects. Sometimes things that don't work is not because they don't work, it's because you can't tolerate them. So maybe there's an intervention we do that can make tolerability better or combat a side effect, right? Like weight gain used to be a crazy difficult to manage. And it's still very, very difficult to manage. Don't get me wrong, it's difficult to manage. We have some options for that, right? And so I think that as time goes on, we have, first of all, nobody gives up, okay? Some people give up, but I can't give up. So when people come to see me, we always come up with something, right? We don't make up, and usually in the past, I used to come up with heroic, like wacky things sometimes. Not too often wacky, but sometimes wacky. Now it's very rare for me to come up with wacky things. When I say wacky, I mean like things that you've never heard of, right? Things that have some dude, some psychiatrist, some academic researcher has put some patients on it, and it worked for some people, right? I'll give you an example of that. When I was first treating people, Lamictal was not available. And so there's a study at the NIH, National Institute of Mental Health. They had these patients that were not responsive to anything. These patients we're talking about right now, they never responded to anything. So they lived at NIH and they just tried everything. And they had one study where they tried gabapentin and Lamictal and one other thing they tried. I forgot what that was. And lo and behold, Lamictal worked there, right? Now we use Lamictal as FDA approved. Gabapentin we don't use as much, and that was effective, right? There's a few other kind of those things that are out there that people have tried that I am aware of that are not widely available. So I used to talk about those things more, But now you don't have to talk about that stuff very much because there's a lot of options, combination of options. So things don't work, but usually we can find something that works.
Thank you. This question is from Carol. How to best deal with weight gain as a side effect of meds?
Oh, that's hard. So it's very difficult. The number one thing is to prevent weight gain, avoid weight gain, be aware of weight gain. Those are the biggest things. I used to do like brain imaging. I used to do efficacy studies. And one of my other areas is weight control. I used to do a lot of studies that looked at weight because that was a big issue for us, right? And it is a big issue now. So being aware of it is important. So what I tell my patients is like, this medication could cause weight gain. And if you gain 60 pounds, I'm going to have a hard time losing 60 pounds. Right. So we got to pay attention at the beginning, right? Not that if you gain 1 or 2 pounds, we just stop. But we got to pay attention because we don't want to gain weight too much because then it's going to be hard to lose. Right. So awareness is really important. Luckily, in the last few years, we have more options that are more weight neutral or don't cause weight gain. So like the old ones, so the atypical antipsychotics can be divided into mainly 2 groups. Some people divide into 3 groups. So it's 2 groups. There's Zyprexa, Seroquel, Risperidone, Acenapine. They cause more weight gain, more sedation, more weight gain. The newer ones, Gedon's one of these, but Latuda, Vraylar, and Caplyta, mostly weight neutral. They're not negative, but they're a little bit slightly positive, but basically neutral. Okay, so those are better. And then what can we do if you do have weight gain, but the medication works really well? Okay, so there are some options you can do for weight gain. So metformin is effective sometimes for people. That's a diabetes drug. There is Topamax, topiramate, sometimes works for some people. If they can tolerate Wellbutrin, sometimes it causes weight loss. Strattera sometimes causes a little weight loss. And then, I was doing a lot of that stuff. And then, you talk to your other doctors about this, but now the Ozempic, that sort of blew me out of the water. Okay. Caused a lot more weight loss than the things I did, but it has, it has this other, haven't used it. People haven't used it that much yet. So we have to see how its side effect profile is down the road. Okay. And there's a new medication called Lybalvi. It's basically a combination of medication. It's looking at Zyprexa plus an opiate antagonist called samidorphan. You might not have heard of it very much. It's called Lybalvi. It's basically a combination drug. And basically what this is it's looking at Zyprexa and preventing weight gain. So they take Zyprexa and give them this opiate antagonist in order to prevent weight gain. Okay. It works pretty well. It doesn't really prevent weight gain. What it does is it limits the weight gain. So it has less weight gain, right? So maybe some people that gain a lot of weight may not benefit from it, but maybe some people that gain a little bit of weight might be something that'd be useful. Okay. So it's still a big problem, but we really need to intervene that. So what I talked about is talking about the medications that work, but really these questions that have come up is like, how do we get these medications to work if there's side effects?
Thank you. I know we're coming up on time, and we have a ton of questions. Thank you for all your engagement, everyone. Maybe we can brainstorm a little bit how we can get these questions later if we don't get to them. The next question I have though is, can you talk about how early intervention at first break affects the long-term health of the person as compared with those who go undiagnosed?
Yeah, so early intervention, there's a lot of programs that are looking at early intervention. There's 2 reasons for their early intervention that are really important. Number one is that, remember that I showed you the chart at the very beginning where you had episodes and then the episodes got faster and they got more mixed. So this process called kindling or progression. The thought is that when you get episodes cause not brain damage, but it causes a little worsening of the brain function, a slight damage, you can't see it. And then if you have that over time, it accumulates. So the episodes get worse and worse. So having fewer episodes is really important. Okay. So some people I have patients that go, well, I'm going to cut myself off so I can have more questions. But so early intervention is important so that it doesn't lead to progression. Okay. And obviously, the second thing that's really important for early intervention is like, again, these people come in when they're in their late teens and the early 20s. This is when their life is supposed to take off, right? So if they don't control their illness for 10 years, then their life is delayed by 10 years. And their friends have moved on. And so then they have to sort of go through life a little bit more alone. So that social construct is a big issue for patients I see, that how to sort of move on in their life, even though they've been have that difficult illness at that part of their life. So early intervention is good because you want to sort of limit the disability that affects their life and delays them. There's a big difference between having a year taken out of your life when you're 50 versus a year taken out of your life when you're 18.
Thank you. Our next question is, can you recommend any natural approaches to address root causes of bipolar 2 with hypomaniac tendencies? Hypobaric oxygen chambers, neurofeedback treatments, etc. This is in addition to medication treatment to complement greater wellness. And a comment of thank you so much.
There's research out there for these kind of things. The research tends to be not super well controlled, and that's why I don't know much about it. I am a researcher and an academic clinician, so I tend to just know a lot about like things that are controlled studies. So I apologize for not knowing that much about that kind of thing. The things that have a little bit more data are like, for instance, I guess it's a little bit natural. Omega-3 fatty acids has some data found effective for mood stabilization. Not a whole lot, but it has some data. Folic acid has some data for depression. Thyroid hormone is not natural, but it has some benefit there. And then there's this movement towards ketogenic diet. That has some benefit for bipolar stability. That's based on the fact that ketogenic diet is effective for seizure disorder. You know, in third world countries where they don't have the medications, ketogenic diet is very effective. And so they tried it in bipolar, and there's definitely cases of that being effective as well. So that needs to be developed further. Other specific diets, not so clear. Exercise is definitely generally beneficial, but it's the studies are hard to come by that are controlled. Sort of one of those things like healthy diet's important, healthy exercise important, but how it has that benefit is not so clear. So other things, the hyperbaric chamber, I'm not really aware of that. Yeah, so this is a field that needs a little bit more research.
Thank you. One of the questions, let me just answer it really quickly. Saying thank you so much. I wish all physicians were as knowledgeable as you are, and there's a big shortage of psychiatrists in the community. Stanford has a good bipolar center, but as we may know, it's not accessible to everyone. How does one find someone who is attentive and can figure out the art? It really is an art, as you said, of how to assist someone.
I don't have a good answer for that. I was just talking to somebody else just earlier this morning, but I try to improve the treatment of bipolar. And we had two prongs. One was the treatments and medication. It's easier, relatively speaking. And the second prong is like getting psychiatrists to, number one, want to treat people with bipolar. It's sometimes a more difficult illness, right? It's not like just anxiety, fear of spiders. That's easy to treat, right? It's more than that. Some psychiatrists don't want to take the time to do that. And take the education to know that it's not depression plus mania. It's all the stuff we talked about today. That takes a lot of education. It takes a lot more effort. And I know my students, my residents, they see what I have to do sometimes in clinic, and they go, "I'm not doing that. It's just too much effort." So it's fulfilling though, because people, don't get bad like the studies show they get bad, right? That is going to be really bad. But people can be very productive. They can have very good lives. And so getting that message out there is really important. I don't know how to find people like that. I only have, if people ask me for referrals, I don't give very many because that's difficult. So in exchange for that, I think that some psychiatrists are closed-minded, right? So we don't want those. But some psychiatrists are open-minded, and they may not know exactly what needs to be done, but they're open-minded in terms of discussion. And so that advocacy for yourself is really important, right? looking at what, like, hey, I've heard about this from Dr. Wang or something. I read about this, right? Coming to these meetings and getting more information and then presenting it to your psychiatrist. A good psychiatrist will go, oh, that's interesting. Let's think about that, right? Bad psychiatrist, oh, that's stupid, right? And it doesn't want to listen to it. So some conversation about that it's much better. And so all my sessions are very collaborative because I don't want to tell you what to do. I just want to give information and come up with a good solution. Yeah, I wish I had a better answer for that.
Okay, thank you. Thank you for trying and your wisdom. Jeffrey, you've had your hand up. Can you speak now for your question?
Yes, thank you. Thank you for your talk. There are many models for treatment settings. Trieste model in Italy, you have CCBHCs, cuffs, even treatment while you're incarcerated. What do you see as the most suitable environment for early intervention, diagnosis, and treating bipolar disorder where patients have the highest probability of having a stable and meaningful life? Thank you.
That's a really good question. I don't have that's a complex answer. It's complex because I could be paternalistic and say when people have bipolar, they should have to do a psychoeducation component to understand how this impacts their life, what the medication options are, what the benefit of treatment is versus sort of the stigma of treatment, balancing all those things out. Can't really force people to do that. All we can do is be welcoming and sort of understanding, recognizing that people have different priorities at their stage of life and sort of respecting that, but then presenting the information. So ideally that takes some time. And so it'd be nice to have some kind of built-in program for that. And there are programs that look at that, but when there's a coercive component to that, it lessens the person's acceptance of the information, right? So people have done different things, and I don't think anything's been really successful. I think that has to be individualized, and that's what I try to do. I try to individualize it based on what the person is willing to accept at the given time. I wish I had a better answer for that. These are really good questions.
Thank you. This is a little more general. On average, how long does it take for someone to find the right medication? And is there a form of therapy that you can recommend to go through while taking medication?
So when we looked at our sample at Stanford, it took 2 years. Now, when people come to us, they've usually seen like 2, 3, 4, 5 psychiatrists. Okay, so they've been on a lot of medications. So that 2 years maybe like longer than you might expect, right? Medications work pretty well, and therapy works pretty well if you start off, right? So I think I think probably within a year or something like that, year to 18 months, you can sort of dial in not only the medication but tolerability, how to manage those adverse effects. Most of the time, I think you can do it in that. That seems long, right? But we're not talking about it takes a year and a half, 18 months to get people stable. I'm talking about getting to the right dose, getting a lot better, getting back to the life, tolerating the medications. Long term, you get into the dose low enough that they can tolerate long term. All those kind of factors put together. That's usually the time frame I put down for people. Like, give me a year to year and a half with just the meds, so it's much more tolerable. Yeah, so I think that's pretty what it is. Oh, and therapy. Sorry, the therapy piece. There's 3 different therapies, maybe 4, that are found to be effective for bipolar. These are studied. The reality is that only one of them is widely available. The other 2 are not fully widely available. So there's family-focused therapy, not widely available. Not family therapy, family-focused therapy. And then there's interpersonal social rhythms therapy, pretty well understood, but not many therapists want to practice that. Most therapists do cognitive behavior therapy. And some people will do dialectical behavior therapy. That's pretty effective for some of the symptoms of bipolar. Not as well studied as the CBT, but it's well studied as well.
Thank you. I have one by Laura, and then next we have Jenna with her hand up. The one by Laura is, can you please talk about the long-term side effects of Seroquel?
Yeah, so Seroquel is one of these first, we call them second generation. So After the Haldol, they came up with another group of atypical antipsychotics, so like Zyprexa, Risperidone, Seroquel, this kind of category. So the main problem with those is, even though they work, is that they cause metabolic issues, diabetes, weight gain, cholesterol problems, those kind of things. And they cause a lot of sedation. Those are the biggest problems. So probably 2/3 of people get that risk, not necessarily diabetes, but weight gain, sedation. So that's the thing to manage. I have people on Seroquel, and it's sort of adjusting the dose. You might get less weight gain, you might get less sedation. If they still can't tolerate it, then you have to come up with something else. Long-term tolerability is really important.
Thank you. Jenna, go ahead.
Hi, thank you. Can you talk about the concerns of people who are using marijuana while they're on maybe something like Vraylar?
You're asking what their concerns are or what my concerns are?
What, you're the doctor.
Okay. My concerns for them, yeah. So so my thinking of this has shifted a little bit, okay, a little bit, which is that 10 years ago, I would say, man, marijuana, man, it's so unknown, and you don't know what you're getting. I had some people that were actually patients that were growers, and it's not my recommendation, but they were growers, and I just knew that they was so uncontrolled what they were getting, right? People were getting, right? They would just grow it and then they pass it off, and people think they were getting what they're getting. I'd say, I don't know if you're getting what you're getting. Okay, so uncontrolled, right? That was my main take before. It's been more widely used, and so there's a lot of safety information, not fully well, that I'm not as negative about it. I'm not positive, but I'm not as negative, right? But this comes to your question. And I mean in general. Right? But in your specific question, people with bipolar, with schizophrenia, with psychotic disorders, it's a risky endeavor. And that's because there's clear evidence that shows that marijuana is associated with psychosis, causing psychosis, leading to psychosis. Not everybody, but definitely that indicate that the link is there. So you take people that have used marijuana, their risk of developing psychosis is much higher than if they don't. Right? So there's that risk, right? And I definitely know people that have bipolar, that when they use marijuana, they get manic or psychotic. You think it sort of calms down, but it doesn't. Now I have people that do fine, but there's more than a average risk of people that use marijuana that are bipolar, clearly for schizophrenia too, that actually get unstable, right? That's number one. Number two is we got to keep in mind what marijuana does, right? Mostly people use it for energy or less depressed or anxiety or something like that, right? There's two problems with that. Number one is that it is something they can take. So it's like something, it's like a medication I can prescribe. The difference is that it's widely available, right? It's widely available. You don't have to get well, you can get a prescription, but you don't have to ask your doctor for every single time you get it, right? So it's easy to unmanage, right? Second thing about that is that it sometimes deals with things that maybe therapy would be better at. So is it better to exercise and improve your health? Or is it better to eat chocolate, which also helps with anxiety, right? It's probably better to exercise because it builds up your health rather than contributes to lack of health. The marijuana doesn't add health, helps with the mental status part, maybe for some patients, but it doesn't give you more coping, right? Like meditation or relaxation or finding friends, things like that. So that's my usual conversation about that.
Thank you. I know we just came about 7:27 for unanswered questions. Therese, can you help me out what we can do for this so that we can close out and respect everyone's time?
Sorry, here we are. Well, we could get the questions and maybe ask Dr. Wang if he's, if we can, we'll look at them and maybe put them together, and maybe you could answer a few if you have time. And I think we can ask him to do that. And we can end now or perhaps stay maybe for 3 or 5 more minutes. I won't do a closing.
But do you
Sure.
want to do a closing first, and I can answer? You can tell me which question you got to end up with, and I can scroll through them.
Okay, you go through the chat, Dr. Wang, and I'm just going to do my last pitch for everybody. while you scroll through the questions. Can you see the chat, Dr. Wang?
Yeah, I can see them.
Okay, so hello, everybody. It's Therese Adams. I'm Executive Director of NAMI, Santa Cruz County. And I just wanted to tell you in the chat, we're going to put in, for those of you who need help, we're here for you. So we have a helpline. So Sophia, if you could put the helpline number in the chat. We also have classes and support groups that are free. You can look at our website. So we'll put that in the chat as well. Everything's free and we're here for you. That was it. That was my
Okay.
pitch.
Can I also put my little tidbit in
Yes,
before
thank
we
you.
close out?
Yes.
Before we close out, we do have an evaluation. We really value your feedback and we want these presentations to be useful for you. So if you would please take the time to fill out the survey, I have posted in the chat. It's a SurveyMonkey link. It's in English and Spanish. It would be really helpful and we really do appreciate your feedback.
Okay, that's great. Do you see any questions that would be a little more easily answered? And then
Yeah,
we'll
I'm going to answer the ones I can. Some of
Yeah.
the more individualized questions, I'm probably going to either skip or just come up with a teaching point. One of the questions was looking at like suvorexant, Belsomra for bipolar disorder. That's a really good question because because of the association between sleep, circadian rhythm, and bipolar. It's thought that maybe some sleep agents, not hypnotics, but some sleep agents like suvorexant, or there are some other ones like some melatonin agents could be effective for mania. I actually studied a melatonin agent before, and but there isn't enough data for that. So we looked at them. I actually did a study for suvorexant for bipolar, and it helped their sleep a little bit, but their mood didn't really get a lot better. Okay, so the signal's like not there. We're hoping that's the case, but didn't really pan out. So that's probably still more complex. Somebody asked multiple questions about the methylfolate reductase. So this is looking at folic acid and bipolar. There's some evidence for that, but I think it's much more robust for depression. So, and it has to do with the fact that there's a certain percentage. So folic acid is basically a vitamin or something like that that we need in the body. And the folic acid in people's body is actually a methylated version of it that becomes active. You need to methylate it. And some proportion of the population can't methylate it very well. And so they may have proponents for some mood disorders. And so the treatment for that is that you can give folic acid, but then some proportion can't metabolize that to the active ingredient. So they get something called methylfolate. It's actually a medication you can buy by prescription. I think it's called Deplin or something like that. And so that's been effective for depression. I use it sometimes for patients, but again, there's not enough evidence to show that it's part of the pathophysiology directly for bipolar. Let's see here. So the therapy in bipolar treatment, I think I mentioned that. The Abilify can cause diabetes. That's true. Abilify in that class medications where there's all these atypical antipsychotics, it's sort of in the middle in terms of risk of diabetes. So Seroquel, Zyprexa, Risperidone at one end, Abilify is sort of in the middle, and then these other ones are a little bit less. So it's sort of this transitional drug. But any of these can cause diabetes. Let's see here. More questions, a lot of questions about Seroquel. It must be pretty commonly used. There's a lot of thank you ones. I appreciate everybody's thanks. Okay, somebody asked a question. A few people, I was going to try to avoid this question, but it's a really difficult question. The question is about complex PTSD, ADHD, and bipolar. That is a super complex question, okay? I'm going to answer it this way. Bipolar is a super serious illness, right? And some people want to have complex PTSD as the reason for their bipolar. Sometimes it could be, but a lot of times it's not, right? Because if you try to just treat complex PTSD, a lot of the treatment focuses on psychotherapy. As I said, and I'm trying to make a big statement of this, bipolar is a biological underpinning. So if you just do therapy, it doesn't have enough power to change the brain the way we need to. So you're going to end up with a lot of, this is me, you're going to end up with a lot of suffering and a lot of effort looking at psychotherapy, and you're going to be treating complex PTSD, but it's really going to be bipolar, okay? So that's my 2 cents about that. It's a big controversial topic I just said. ADHD is somewhat similar to that. A lot of people say, I think I have ADHD. I have patients like right now, like I stabilize it. They come to me, they're like unstable. I stabilize them with mood stabilizer and they go, I think it was probably just ADHD. I go, no, you have ADHD symptoms now, but you definitely had bipolar symptoms that you don't recognize now because your mood is stable. But when they're not doing well, they recognize the mood, but when they're not doing well, they hope they don't. So I think it's just, we just have to be honest with ourselves with what's happening. And sometimes we don't recognize it because of memory bias. Like we don't remember that, right? But that's when we have to have help, right? Okay, I think that is pretty much, no, it's not it. People keep asking questions.
Okay, we'll take 3 more and
Yeah.
that we'll call it a night.
Okay.
And
I
we'll
think
have you back if you could come
Yeah, I
back.
think that's pretty much
Yeah.
it. I think the last one is looking at trauma and bipolar. Ugh, that's a hard question too. These are hard questions because these are things that we're thinking about, right? So we found a gene that if you have a certain allele, okay, then, and you have trauma, then you have bad bipolar. It doesn't cause bipolar. It doesn't mean that trauma causes bipolar, but it means that if you have this, if you have trauma and you have bipolar and you don't have this gene, then you might be just have regular bipolar. But if you have this gene and you have trauma and you have bipolar, oh, if you have the gene, but you don't have trauma and you have bipolar, then you have regular bipolar. If you have this gene and you have trauma and you have bipolar, then you have really bad, rapid cycling, complicated bipolar. And that might be, those might be people that look like they have complex PTSD, right? So that gene, again, there's these modifiers I'm talking about. It's not that it's not bipolar, it's that this gene makes the complex PTSD look really, really bad. But it's still bipolar. There's underpinning bipolar. Because if you look at their family, they have bipolar. Okay? I'm going to stop right there, okay? Because it could just go on for
Yes.
this is
Yes.
really
Thank you.
Yeah, so thank you so much. We so appreciate you for coming, Dr. Wang. Really, very interesting night. So we'll discuss this further. I want to thank Alex and Sophia for putting this on, and Beatrix for translating. And so I see that this is a topic we need to have further discussion and maybe advocacy so that our physicians in our county are better educated on bipolar disorder. So we have an advocacy point. We do that well here at NAMI. So it seems like that's a point that I'm taking away from here. So, okay, thank you all.
Well, I'll say one thing.
Oh, yes.
So we had a study that we wanted to look at TMS for bipolar, and we needed somebody with skin in the game, right? So, and we needed you to be part of the study, but we couldn't find anybody. So it was interested in that kind of thing. You know, our research arms are interested in that kind of collaboration.
Yeah, so send us, so you have Sophia's email?
Yeah.
And we'll send it out with our, we have a big e-news, and so we can send it out to our people.
Yeah, cool, great.
Yeah,
Dr. Wang.
thank you.
Very much.
Thank
I
you.
really appreciate it. I really appreciate it.
Bye.
Thank you. Bye-bye.
Beatrice. I'll stop the recording now.